talking about the pharmacological treatment of psychotic disorders. Um, so before going into the management, just briefly touching upon what is psychosis, which most of us now know through the series of these trainings and otherwise. So it's basically a medical syndrome that can be diagnosed based on a cluster of characteristic changes in a person's thinking, feeling, and behavior. During an episode of psychosis, persons can struggle to differentiate between what is real and what is not, and they may come to believe false explanations for their experiences. So, what are the common signs and symptoms of psychosis? So, we see something that is essentially called as positive symptoms. So, these are called positive because they add to an individual's normal functioning, or they could distort an individual's functioning, perception, or behavior. Common symptoms, which are called positive symptoms, are hallucinations, delusions, paranoia, or suspiciousness, bizarre behavior, disorganized communication. Negative symptoms, on the other hand, lead to a reduction or loss in an individual's normal functioning, perception, or behavior, which is why they are called negative, because they deduct from your baseline functioning. So, decreased motivation, decreased energy, poor speech production, social withdrawal, flat affect, unable to enjoy anything, poor hygiene, a decline in general functioning, all these would classify as negative symptoms. Then what we see is cognitive symptoms, which could be a decline in executive functioning, attention, working memory, learning. There could be a significant preoccupation with their symptoms, maybe, thought blocking, and a reduced abstraction ability. Mood symptoms are often noted as a part of psychosis or as an add-on to the ongoing psychotic episode. There could be mood fluctuations, there could be anxiety, depression, irritability, suicidal ideation. So the therapeutic targets in psychosis are what we just discussed, some of the symptoms like delusions, hallucinations, mood symptoms, any psychomotor agitation, any sleep disturbances, and the pharmacological treatment, the mainstay of pharmacological treatment is antipsychotic medication. We also at times end up adding other class of medications like antidepressants, mood stabilizers, anxiolytics, but antipsychotics remain the mainstay, and which is what the focus of today's presentation is going to be. So what are antipsychotics? These are basically medications which are used to help manage symptoms of serious mental health conditions like schizophrenia, bipolar disorder, and severe depression. And how do we classify them? So traditionally, they are divided into two groups based on when they were introduced. The first generation are the older drugs, which came before the 1990s, and the second generation are the newer drugs, which came after the 1990s. So both of them are effective. There's some differences in the side effect profile, which we're going to talk about. So basically, antidepressants work on dopamine. And what does dopamine do? Dopamine works to maintain your attention. It has functions in motivation and reward. It regulates neurohormonal balance, like you're regulating prolactin levels. It regulates movements, and a disturbance in dopamine could lead to involuntary movements. It regulates energy levels, nausea. Psychosis is not a function, but an elevated levels of dopamine are seen in psychosis. Now, there are some important regions in the brain where dopamine tracts are seen. So this is the midbrain, this is the cortex. Here's the basal ganglia, and we have the hypothalamus and pituitary here. So the mesocortical pathway runs from the midbrain to the cortex, which mainly works in regulating motivation, attention, and general cognitive functioning. This gets impacted in negative symptoms. The pink one here is the mesolimbic pathway, which is basically implicated in addictions and in psychosis. It is the reward area. The nigrostriatal pathway, it regulates movements, and this gets affected in extrapyramidal side effects, movement disorders. And then we have the tuberoinfundibular pathway, the small one here, which regulates neurohormonal functioning. And if this pathway gets affected, there could be prolactin inhibition and a host of side effects that we can see. So, the first generation are also called as the typical antipsychotics or FGAs, and the second generation are also called as atypical antipsychotics. So, the typicals, they are dopamine receptor antagonists, but the atypicals act on both serotonin and dopamine. Now, the typicals are more effective against positive symptoms, uh, but they could actually produce what you call as a negative symptom state, or they could worsen negative symptoms, causing a host of side effects like bradykinesia or slowed movement, flattening of affect. They have a higher risk of EPS, which could mimic the negative syndrome of psychosis. Common examples are chlorpromazine, fluphenazine, haloperidol, prochlorperazine, thioridazine, trifluperazine, all the zines and dols you can see here. While the atypicals or the serotonin dopamine antagonists are effective against both positive and negative symptoms. And you must have heard about olanzapine, risperidone, aripiprazole, there's clozapine, paliperidone, ziprasidone. These have a lower risk for extrapyramidal side effects, but they have a higher risk of metabolic side effects. Now, antipsychotics can be used anywhere you can see psychotic symptoms. So, psychosis is not a diagnosis as such. Psychosis can be seen as a part of another diagnosis as well. So, schizophrenia is a type of psychosis, schizoaffective disorder is a type of psychosis, bipolar disorder can have psychotic symptoms, delirium patients can have hallucinations or delusions. Fluctuation in their orientation. You can give small doses of antipsychotics there. Severe depression or psychotic depression, you can see a prescription where an antipsychotic is prescribed. Don't be surprised. Also, it can be used for augmentation in treatment-resistant depression or anxiety disorder, in dementia, where you see the behavioral and psychotic symptoms, and other disorders like impulsive compulsive disorders, for example, augmentation in OCD or trichotillomania. All of these disorders you have place for antipsychotic use. Now, how do you make sure you are using them safely and effectively? It's important to start low and go slow. So, we should use the lowest effective dose for each individual. And if there is no adequate response, you increase only after 1 to 2 weeks of watchful waiting. Long-acting injectables, their levels continue to rise even if you're not changing the dose. So, you have to be patient by monitoring these patients. Uh, you have to prefer starting them after establishing an effective oral dose wherever applicable. And they offer a better relapse prevention. And it's important that we consider using them early and not as a last resort. Avoid polypharmacy. One antipsychotic is usually enough. Combinations should be used only when strictly necessary. For example, treatment resistant psychosis, to augment clozapine, you can add another antipsychotic. It's also important to monitor closely for the side effects that I'm going to talk in the coming slides. Also, it's important to use sedatives wisely. Avoid using antipsychotics as needed for sedation. If a person needs sedation, we can offer short-term benzodiazepines or promethazine when required. It's important to monitor and document a patient's progress to maintain objectivity. If possible, use rating scales to assess their response. Also, regularly monitor their vitals, EKG, glucose, lipids. It's important to withdraw carefully. Slow tapering using a hyperbolic regimen, because antipsychotic withdrawal can lead to a host of symptoms which can be disturbing. Um, One moment. I think I missed a slide. Yeah. So when you see a patient who's presenting with psychosis, especially for the first time, you discuss the treatment options. It's important to agree on the choice of antipsychotic medication with patient and or their caregivers. If that's not possible, or if they don't have a choice, start a second generation antipsychotic medication. If possible, go for one that is also available as long-acting injectable. Titrate to minimum effective dose, start low, go slow, as we discussed. Adjust the regimen according to therapeutic response and see if the patient is able to tolerate the dose that is being prescribed. If usually you would see an effect by 2 to 3 weeks, at least initial effect would be seen, and then you can increase the dose of the drug or change the drug. If there is some response detected, you continue the drug for 8 to 10 weeks. So you continue seeing the patient over 2 to 3 weeks. If it's effective, you continue. And before discharge, if it's an inpatient, try to switch them to a depot or a long acting injection. If you do not see an effect, you change the drug and you follow the above process from the start. But still, if there is no effect, you consider clozapine and make sure that both a second generation and a first generation have been tried before clozapine is being considered. Uh, if the patient is not able to tolerate the medication or there's poor adherence, it could be related to some side effects that the patient is experiencing. Discuss with the patient and change to a drug with more favorable adverse effect profile. And when you have established efficacy and tolerability, consider switching to a long-acting injectable. So, it has been shown that antipsychotics significantly reduce relapse when compared to placebo. 26% of medicated patients did not relapse compared to 61% of them treated with a placebo. Uh, Standard recommendation for treatment for somebody with a first episode of psychosis, at least 1 to 2 years of treatment following the first episode. And then the medication should be carefully tapered and stop only if the patient has been symptom free. There are certain risks that come with discontinuation. 80% patients have been shown to relapse after being 1 year off meds, in 98% after 2 years, and most who stop relapse within 1 to 2 years of stopping the drug. These are persons with long-standing psychosis. There was a Swedish study that has shown that there is a 50% reduction in hospitalization if patients have been treated for at least 5 years compared to those who have received treatment for less than 6 months. There are exceptions. You might often hear somebody say, "Oh, I know someone with psychosis. They just had one episode and they never needed medication. Medicine is not really needed." Yes, there is a small percentage of patients who may not require long-term treatment, but there aren't very strong, reliable predictive factors except cannabis use. So consider what form of medication is most acceptable to patient. There are oral medications available. There are also some liquid forms available for some of the drugs. There are long-acting injectables which show better adherence and outcomes. Choice of antipsychotic has to be discussed with the patient. There is evidence to show that clozapine and olanzapine reduce readmission risk more than other meds. Um, then stopping strategy, as I discussed, it has to be a hyperbolic tapering regimen. We're going to talk about it a little bit. Early relapse signs should be recognized by patients or their caregivers or their providers. And it's important to have a holistic approach. Antipsychotics are not the only solution, although they are a very important part of the treatment. We have to consider psychosocial interventions and psychological interventions. Um, Talking about negative symptoms, these are symptoms that are often refractory to treatment. So we haven't found clinically significant or enduring benefit for negative symptoms as a primary outcome in research. Some improvement in trials is often limited to secondary negative symptoms. Let's say somebody has negative symptoms secondary to the positive symptoms or secondary to the medication. Early identification and treatment of psychosis may reduce the risk of developing negative symptoms. So, what we do at the STEP Learning Collaborative and the STEP Clinic is we're trying to reduce the DUP or duration of untreated psychosis. And this has shown some positive effect in reducing the incidence of negative symptoms or the severity of negative symptoms. Um, Now, what management strategies one must adopt to treat negative symptoms? It's important to use lowest effective dose. There has to be a good balance between efficacy and side effects. As I earlier mentioned, EPS or extrapyramidal side effects could present like negative symptoms. If there is comorbid depression, it's important to identify it and treat it. We must consider environmental factors. Let's say if somebody is institutionalized or there is lack of stimulation, they are homebound, they do not have much exposure to people around them, there's lack of social stimulation. All of these could also contribute to what could present like a negative syndrome state. Um, And like we said, there's no evidence for any specific treatment for negative symptoms. We could consider a trial of add-on medication, like an antidepressant or another antipsychotic may be considered. Also, it's important to minimize drug interactions and adverse effects when more than one drug is being used. Talking about side effects, motor side effects are often the most talked about. What we acutely see is dystonia, akathisia, and Parkinsonism. Dyskinesias are often seen towards longer term of treatment. So dystonias are like painful muscle spasms that can be seen with acute antipsychotic use. Parkinsonism presents, or pseudoparkinsonism, it could present with a tremor, bradykinesia or slow movement, rigidity, postural instability. Akathisia is it presents with both motor and psychological restlessness. So, if you see a patient who has recently been on antipsychotics and now they're not able to sit still, they have a need to constantly move, they're very restless, that is something that could look like akathisia. Cognitive symptoms like psychomotor slowing, I'm sorry for the typo, sleepiness, affective symptoms, flat mood, social withdrawal, evolution, cardiological side effects like there's increased risk of arrhythmia, there could be a prolonged QT interval or corrected QT interval, there could be postural hypotension. Endocrinologic side effects, hyperprolactinemia, which could lead to amenorrhea, galactorrhea, gynecomastia, and sexual dysfunction. Autonomic side effects like constipation, dry mouth, accommodation disturbances, which could impair a person's vision, urinary retention, and there have been some case reports about this. Metabolic side effects like increased weight, increased appetite, dyslipidemia, diabetes. We need to monitor the patients closely for these side effects, and we're going to talk about this in the next slides. So before you start an antipsychotic, there need to be some baseline assessments which need to be repeated at frequent intervals. So a urine routine, kidney function, full blood count, fasting lipids, fasting glucose, monitoring person's weight, BMI, and waist circumference. EKG, blood pressure, prolactin levels, especially with certain drugs like risperidone, liver function, creatine kinase. Some drugs require careful monitoring, especially clozapine, where you do more frequent full blood counts because there have been risks of neutropenia and other risks. Rare instances of thyroid dysfunction have been reported with quetiapine, so you might consider thyroid function testing. And of course, with clozapine, you need more frequent EKG, liver function testing. You would also require an EEG because clozapine lowers the seizure threshold. So you need to be very cautious before prescribing it to somebody with an existing seizure disorder. I'm just going to touch upon some of the important drugs. Haloperidol is a very commonly used first-generation antipsychotic. It targets delusions, hallucinations, aggressive or violent behavior, positive psychotic symptoms that we mentioned. So it can show early improvement in psychotic symptoms as early as a week, and you need to continue it for a sustained period of time to have a sustained improvement. Oftentimes, it is also used as an injectable, acute injectable form to control psychomotor agitation or excitement, where you need to closely monitor for side effects. So the side effects could be affective and cognitive, motor side effects that we discussed, endocrinological side effects that we just discussed in the previous slide. It can have some metabolic side effects. Also, it can lead to a low blood pressure and sedation, so it's important to give the medication at night. Some dangerous side effects like arrhythmias, neuroleptic malignant syndrome. You need to identify these. So important to do an EKG, monitor their QT, corrected QT intervals. At least EKG should be done once a year. If you see any symptoms like rigidity, hypothermia, agitation, you should check for their CPK levels or creatine phosphokinase levels and immediately discontinue the drug because this is life-threatening. Also, you would not give it to a patient with an existing movement disorder like Parkinson's disease. Then the second generation popular drugs, risperidone, olanzapine, aripiprazole, each of them has their own personalities. So risperidone tends to act more like a first generation drug. So it has motor side effects, it has endocrinological side effects at high dosage. So you need to monitor accordingly. Olanzapine is really efficacious, but it has a high burden of metabolic side effects. So you have to monitor them for weight gain. You have to monitor their fasting glucose, fasting lipids, monitor their BMI and metabolic profile regularly. Aripiprazole has very favorable tolerability. There is no weight gain, no sedation, no EPS. Uh, Though it can be mood activating, it can make a person a little agitated. They might appear restless. It may also lead to insomnia. So you could consider adding a benzodiazepine if necessary. Clozapine, this is a drug that can be considered for treatment-resistant schizophrenia. What is treatment-resistant schizophrenia? It is defined as two failed trials with antipsychotics. At least one of them has to be a second-generation antipsychotic. Side effects with clozapine use, sedation, low blood pressure, sialorrhea, or increased salivation. Often they will complain that my pillow gets wet at night or they're drooling. Weight gain, agranulocytosis. So the absolute neutrophil count decreases. That is why we do a full blood count for these patients. Initially, we do it weekly, then we do it at 15 days interval, and then we taper it to monthly from the second year. Also, diabetes, dyslipidemia, because it's a second generation, you have to monitor their metabolic profile. Now, advantages are that it's helpful for treatment of treatment-resistant schizophrenia. It can be used in violent aggressive patients, persons with suicidal risk, persons with tardive dyskinesia. Tardive dyskinesias are abnormal movements where you tend to see oral, buccal, lingual, masticatory movements, like, they're chewing. And these are usually observed after a long period of treatment. Again, the disadvantages would be the metabolic side effects. Clozapine does have plasma drug level monitoring available, although it is available at very few centers. Um, Also, prescribers have to be informed that there could be a high risk of side effects, especially agranulocytosis. If you see a high temperature, tachycardia, or increased pulse, if you see a postural drop in their blood pressure, if the patient looks clearly oversedated, also watch for any signs of constipation or flu-like symptoms, chest pain, dyspnea, tachypnea, or any adverse effect that is intolerable. Clozapine needs to be monitored acutely for any side effects. The good news is that many countries, developed countries especially, have a registry for clozapine use. So the risk evaluation and mitigation strategies program for clozapine mandated US prescribers to participate in this program and to report results of absolute neutrophil counts before pharmacies dispense clozapine. So this doesn't mean we do not have to monitor their accounts. It's just that you're not mandated to report it any longer. So that's a good news, and that's a recent update. Talking about long-acting formulations, these are basically oily preparations that are given to patients, and they continue to release the drug in the patient's body over a sustained period of time at a certain frequency. So these help reduce relapse, they help in reducing hospitalizations, and there are several advantages over oral antipsychotics, like they ensure therapeutic adherence because the patient does not have to pop the pill every day. Uh, there is less impact on a person's quality of life because now they don't have to take pills every day, uh, ensuring that they receive an injectable formulation every couple of weeks or months. You know that they're being treated. It avoids intentional ingestion. So there are instances where persons can have suicidal ideas or impulsive suicidal behaviors where they could do an intentional drug overdose. And it also favors regular monitoring to the service. Some antipsychotics which I have listed, I know this table is overwhelming, but just for you to know that aripiprazole, flupentixol, fluphenazine, haloperidol, olanzapine, paliperidone, all of these are available. And these can be given at a frequency of 2 to 4 weeks or 4 to 8 weeks or monthly. Paliperidone is also available in a 3 month and 6 month formulation. We also have pipothiazine, risperidone, zuclopentix all available. We need to know the nature of each of these drugs. Olanzapine, for example, can lead to a post-injection syndrome. There are other side effects that can be observed with other LAIs, so we need to know them before prescribing. It's important to go through the label carefully, and the patient can ask any questions they have about the LAIs. Um, about stopping the drug, that's a question that a lot of people have, especially for somebody with a first-time diagnosis. They're like, am I going to be on these medications all my life? Or if a patient has been doing well for quite some time, they wonder whether I can stop the medication. And often they would come to you as prescribers or non-prescribers and discuss these concerns. So it's important to consider whether the patient is symptom-free, and if yes, for how long. What is the severity of adverse effects? Whether a person has severe EPS or tardive dyskinesias or sedation or a lot of weight gain, and now they want to stop these medications. Just see how impacting they are on the patient's life, and also, of course, if the patient has been symptom free, you need to think around that. What was the previous pattern of illness? Consider how fast was the onset, what was the speed of onset, what was the duration of the episode, how severe are the episodes. You might have some patients who develop a psychotic episode and they become severely agitated. They could also have grandiosity and they might just drive fast during that episode, or they might engage in risky behavior during the episodes. So whether there are any dangers posed to self and others. Also consider if in the past there has been a dose reduction attempted and what was the outcome. So you could go and say, hey, John, hypothetically, the last time we tried to reduce your risperidone, do you remember what happened? Or, if you have a caregiver to corroborate what happened when you tried to reduce the dosage, their psychotic symptoms came back or worsened. So that could be historic evidence to bring forward to the patient. What are their current social circumstances? Is this a period of relative stability? Are you anticipating any stressors? Are they going to get married? Are they going to have a new job? Are they going to move? Is there a change in their living environment? Is there a change in their caregivers? There has to be a period of relative stability before you consider stopping or tapering the medication. What is the social cost of relapse? Is this patient the sole breadwinner for a family? So you cannot risk this person going into another episode, because another episode could also mean a loss of functioning. Uh, Also, it's important to understand if the patient or caregiver are able to monitor symptoms. And if there is a relapse, will they be able to identify the early symptoms of relapse? Will they be able to seek help? Always remember that targeted relapse treatment is much less effective than continuous prophylaxis. So the patient might bargain with you saying that, okay, fine, I take full responsibility. If I have symptoms again, I'm going to go into treatment again. But that becomes a little more challenging compared to if the patient was on a regular dose of, at least a low dose of antipsychotic. So, also those with a history of aggressive behavior, serious suicide attempts, those with residual psychotic symptoms should be considered for lifelong treatment. So, in those patients, you would obviously deny the possibility of stopping medication. But it's important to talk through it with the patient. Now, in practice, it's important that all patients are informed of the risk of withdrawal symptoms on stopping or reducing the dose of any antipsychotic, including insomnia, potential risk in psychotic symptoms. Stopping them abruptly or too quickly is likely to precipitate a relapse and severe withdrawal. Also, hyperbolic dose reduction is preferred over linear reduction. I've given an example below. So you need to very cautiously reduce the antipsychotic drug, especially in long-term users. For somebody who's been taking the drug for 5 years and 10 years, you can try a test reduction of 5 to 10% of dose as a starting point. And in those who have been on medication for a shorter period, let's say less than a year, you could attempt a reduction as large as 25%. So a hyperbolic reduction is different from a linear reduction. So you do not reduce olanzapine, say, from 20 to 10 and then to 5 and then to 2.5. You reduce it in a different fashion until it is completely stopped, usually over a period of 1 to 2 years or longer. Now, range of withdrawal syndrome symptoms that can be seen with antipsychotic withdrawal. These could be dopamine withdrawal, there could be withdrawal dyskinesia, Parkinsonism. Rarely these things have been seen during the withdrawal of the antipsychotic. Cholinergic withdrawal symptoms like agitation, insomnia, anxiety, dizziness, nausea, vomiting, diarrhea, myalgia, rigidity, agitation, fear, hallucinations, confusion, disorientation, hypothermia, sweating. Histaminergic withdrawal symptoms can be seen. There could be a lack of appetite, nausea, irritability, insomnia, agitation. There could be tremor, lethargy. There could be dopaminergic withdrawal symptoms because of its effect on the mesolimbic or striatal. Auditory hallucinations could come back, persecutory delusions, other psychotic symptoms may be seen. With the second generation, you could see serotonin withdrawal symptoms, so flu-like symptoms, paresthesia, shock-like sensations, anxiety, agitation, uh, host of other effects. Adrenergic withdrawal symptoms like headache, anxiety, or agitation can be seen. Rise in blood pressure, rise in pulse, palpitations, cardiovascular side effects. These could be seen. I've just listed all of these for future referral. Um, Also, I have emphasized that antipsychotic are not the only pillar for treatment of psychosis, but they are an important pillar. Some add-on medications to the treatment for the treatment of psychosis could be antidepressants, mood stabilizers. You must have heard of lithium, Depakote. Benzodiazepines can be given short-term as PRN, uh, and other medications. There's a lot of other drugs out there. Uh, there are nutraceuticals like coenzyme Q10. There is a fish oil, then ginkgo. We are currently working on a trial using MidoQ, which is like coenzyme Q10, just to see if it affects the oxidative stress pathways and mitochondrial function and leads to any additional improvement in patients with ongoing treatment for psychosis. Um, Also, some things that need special consideration is catatonia. We have an upcoming presentation on catatonia by Dr. Sarah Riley in the STEP program. So catatonia is a syndrome which has a very unique presentation. And for catatonia, you would essentially prescribe them benzodiazepines at relatively higher doses, or you might consider ECT. Catatonia could be a part of psychosis, or it could be a part of other mental illness or neurological illness. But catatonic schizophrenia used to be a separate category in the previous DSM. Then acute agitation and psychosis needs a different approach where you might consider giving an injectable antipsychotic to contain their behavior. You would, of course, try verbal de-escalation and other strategies before injecting them with something. It's important to monitor their vitals. It's important to monitor their functioning, and they need to be in close monitoring for those couple of hours or days when they are being prescribed injectable antipsychotics in an acute setting. Uh, Also, management of medication side effects. We've spoken about motor side effects like dystonias, dyskinesias. That itself is a separate topic, and I'm not going into the details of this. So now you've given antipsychotic, but you've caused another problem, and now you need to treat that other problem. So prescribers need to be aware of this. Some rare side effects like clozapine could cause myocarditis. You need to be aware there have been some reports of increased incidence of pneumonia, and it needs to click. So, but these are like really rare side effects. Then pharmacogenetic profiling, it has become a new thing. So there are certain enzymes that metabolize our drugs, and there are patients can be categorized as fast metabolizers or slow metabolizers. So you can know their metabolic profile, which could impact drug metabolism. So that kind of testing can be done to guide treatment, although it has not become popular in common practice yet. It's important to know factors that could impair drug availability. For example, smoking and clozapine. So smokers tend to have lower blood levels of clozapine, but if a person stops smoking, clozapine levels could go up, and that could precipitate toxicity. So somebody who's been taking clozapine in the community and now gets hospitalized and has no access to cigarettes, uh, their clozapine levels could go up, and you need to be cautious. Um, it's important to consider psychotherapy and psychosocial intervention. At STEP, we offer coordinated specialty care for psychosis, which has all of these elements. And these are very, very important in a patient's management and improving their long-term functioning. So if you see signs of psychosis in someone, you can, of course, contact our referral line. If you're a prescriber, a care provider, make sure the person gets into care earlier. Treatment works, the earlier, the better. And as I mentioned, reducing the duration of untreated psychosis has better outcomes in overall functioning of an individual.